So we'll start right away. We'll start with the, I think we have all the presenters here, or acha. Okay, so we are starting with the first, Dr. Prasanna Venkatesh Ramesh. Dr. Prasanna, please come for your presentation. Dr. Prasanna. He's not there.
Okay. We move on to the next one.
Yeah, we'll go to the next.
Yeah, let's move on to the next one. Dr. Suman Sharma. Dr. Suman Sharma here? No. Okay, let's move on to the third one. Dr. Sagarika Patyal. Hello, Dr. Patyal. Please come in, and Dr. Sagarika will be presenting on indication, results, complication of Ahmed glaucoma valve along with ocular procedures. Can we get her talk? Yeah, thank you.
So thank you very much. Since it's 5 minutes, I'll begin. So we have talked about, this is a non-comparative series of various types of glaucoma in which we did Ahmed glaucoma valve along with other things also. So we know that what is an Ahmed glaucoma valve. I have shown one where we have put it into the anterior segment and one from the posterior segment. These were the case series from 2020 to 2024. And in 2020, of course, we had very few cases, retrospective analysis of our own cases of 22 eyes implanted with either anterior or a posterior tube implantation for various ocular disorders. And it was a single procedure or in conjunction with other procedures or following some procedures. Number of patients were only 22. We had males 17, females 5. Age range was vast, between 55 and 75. We had 3 one-eyed individuals who underwent AGV. Now, preoperative IOP ranged between 27 to 56. Whenever there was pre-op raised, IOP was treated with acetazolamide 3 times a day, brimonidine with timolol and dorzolamide. If IOP did not reduce to a normal level, approximately normal level, then we gave injection mannitol prior to surgery. We had to do, in all cases of NVG, PRP and an anti-VEGF was given. This was done by the VR surgeon. Now, the Ahmed glaucoma valve, which was used in all cases whether it was anterior or posterior, was the FP7, made up of medical grade silicone, overall length being 41.4 millimeter, which is very important, plate length being 16 millimeter, surface area being 184 millimeter square. Types of systemic comorbidities, diabetes was maximum. Amongst others, we had diabetes and hypertension in 2, and coronary artery disease, which is very important, in 3, and the rest, of course, UTI in 2 lady patients. NVG, because of the etiology of the cases, were mainly NVG due to diabetes mellitus in 10 cases, and then we had NVG and with CRVO, and of course uncontrolled because of uveitis, post-silicone oil-induced uveitis, post-VR surgery due to RD, post-trauma, severe trauma with secondary glaucoma, post-ACIOL, and post-central retinal artery occlusion. Types of surgical procedures were AGV with tube in the anterior chamber, tube in the vitreous cavity. 17 were in the first, 4 in the second. AGV we did with scleral patch graft in 20 with a lenticule, 2 lenticules, corneal lenticules in 2. The others, of course, with cataract surgery. AGV with PPV and endolaser in 4 cases where we put the tube in the posterior chamber. AGV with glued IOL in 1 and with scleral fixated IOL and Adidia IOL in 1. I'd like to just show you the type of surgery that was done. It's the simple same thing which we do in every case, and after nicely dissecting it, priming the valve, putting in the valve, and after that suturing it, and that's about it, and then putting the scleral patch graft, and then we have the next one is tube in the posterior chamber. This was a special case where it was one-eyed 75-year-old male with ACIOL, and mitomycin was done with, and we did an AGV, PPV, endolaser tube in the vitreous cavity. And this was a very, very tough case. But then again, and you can see that I have made the, even holding the superior rectus was very difficult. I made an incision much behind than what we make. And you can also see the the glued IOL. And of course, the rest of the thing is the same. And where the tube had been, where the PPV had been done by the VR surgeon after doing the vitrectomy and then the laser, after that, of course, we put it in the same port as the VR surgeon had made. Surgical technique has already been described. And posterior fixation of the tube was done. In this, we always try to make a scleral fixated partial thickness flap, and after that again put another partial thickness flap. But in one case, we could only cover the tube with the scleral patch graft. In 2 cases, the AC placement of tube, the scleral part of the graft was covered by 2 corneal lenticules. Severe trauma, we had 2 cases, and here we have where I will just show you a little bit of the how we put in, this is after putting in the tube. Now we were doing a scleral fixated lens, and this is the aniridia lens which was implanted into the eyes. And this patient has done very well. It's 2 years follow-up now. And post-operative vision, we find 2 patients did not regain any vision. One patient had uncontrolled diabetes. He lost his vision after surgery. It was his only seeing eye after AGV and PRP anti-VEGF. On 2 years follow-up, when he came, he had lost his vision. Second was a case of CRAO, where we had to do this procedure because the patient had extremely high intraocular pressures. One was a case of, third was a case of chronic angle closure. She had a mature white cataract and had neovascularization of the iris, which is unusual in the case of angle closure glaucoma, therefore being presented, and did not regain any
Dr.
vision.
Sagarika, do you
Yes,
want to?
That's it. That's it. Complications we've seen, a tube erosion, repair with, and of course partial thickness graft, and hyphema we had in one case.
Thank you, Sagar. I think a nice
Thank you
case.
very
What was your primary outcome? What do you want?
What the primary outcome, these were varied cases, Dr. Pandav. And therefore, it's very difficult.
But the study
itself is showing us that even if you have the most difficult cases, you read these procedures with the help of your VR surgeon.
To define that you are successful, I mean, you looked at the IOP, or you looked at the visual acuity, or what is the main parameter?
IOP. Most important is IOP. Yeah, the IOP was reduced.
Okay, so I was wondering, some of your cases, you actually had multiple procedures. Like you had AGV, you also had the cyclodestructive procedure done. So in that case, how would you attribute?
We didn't have any destructive procedure. What we were doing was only that suppose a patient could not be taken up for a PRP earlier, pupil was not dilating, the patient's condition was such, and so these are all patients who come to
There was no case where you did AGV with vitrectomy and cyclo.
No,
it
was only the removal of, doing a PRP on the table.
On the table. Okay, thank you very much. Any questions from anyone from the audience?
Dr. Sagarika,
okay.
Have you used mitomycin in any of these cases? There is conflicting evidence regarding the use of mitomycin for Ahmed valve.
Sir, we have used in some cases, very few of them, because I've found that without it also it works very well. But in those cases where we found that first of all, I definitely exclude that the patient is not myopic. And second is that we know that the patient may have a higher rate of failure, the patient is only one-eyed, then we use a very, very dilute, only 0.01% per milligram per ml. We just use it for a minute just to help us out.
That's the homeopathic dose.
I don't know whether, it's
that's a homeopathic dose.
No, but the thing is that Dr. Ramanjit Sehota has showed that 0.01%
Thank you.
works.
Thank you.
We can go to the next.
Thank you. Thank you, sir.
So the next presentation is from Dr.
Prasanna is here, I think. Dr. Prasanna, are you ready? Yeah.
Prasanna Venkatesh, 441. Yeah, thank you for this opportunity to present on a validation of our MIG simulator, which is a cost-effective and a simulative learning. So I got this idea when I was doing one of my MIGS cases. So as you can see, the first stent was superficially implanted and it fell off. And the second stent was then implanted first, followed by then retrieving the first stent, and then I had to reassess myself and take it out and then go back in. But again, in the initial days, there were not much of teaching videos, and I lost the stent again in the corneal incision. So I had to go back and take it back and then go back and re-implant it. So all of us, MIGS is something that is highly coming up in glaucoma, and all's well ends well. So we went back to our drawing board and we wanted to make something for MIGS, because MIGS is something that is upcoming, and we wanted our glaucoma fraternity to train in MIGS in a very easier, cost-effective and very portable manner. So we went to our drawing board and we developed a 3-dimensional, or rather 4-dimensional holographic MIGS training system. As you can see here in my hands, with this headset you can actually go into this training and you can actually implant stents, you can do a bang, you can do a KDB procedure in the exact location with confocal angle images is what we developed and we patented it. So this is the patent that we have done, and we wanted to analyze how wet lab training is different to a simulative training, because in MIGS the god's eye is not suitable for a wet lab training. The angle structures are collapsed, so we don't get to train in a wet lab. Compared to a cataract and wax eyes, the angles are totally different. So we wanted to really have a mimicking system, and we had various postgraduate institutes, 30 glaucoma fellows participated. We did a roadshow in 3 months, October to December 2022. And the questionnaire was, after a focus group discussion among a pilot group, was it adequately prepared for real surgical procedures after completing the simulagical training? Many people had a orientation to MIGS as to what it is, what is a direct gonioscope, how should we have the spatial orientation to go about performing this, and did the simulator help in hand-eye coordination? Because the three-dimensional hand-eye coordination is something that was very, very satisfied, and the satisfaction level in simulative training on a tactile level. So with the haptic that you have, the pseudo-haptic sensation when you catch it and when you click it, especially into the finite trabecular meshwork, there was that pseudo-haptic sensation that we have along with this HoloLens. Adequate visual feedback, just like how you get for any MIGS surgery or any microsurgery. And as I told you regarding the feedback to improve your surgical skills, that also you can see the good and okay people were more. And the confidence in approaching a new procedure, especially when you are thrown into a deep end, the confidence in approaching a new procedure, again satisfied and neutral, more people were there. And making mistakes during surgical procedures, the reduction of likelihood, especially when you're dealing with something as microscopic as your fingerprint, be it the eye stent inject or the bang or the KDB, no financial disclosure and anything, but these are all very finite and very infinite procedures. Accessibility to a simulator again was one thing. In every tertiary center, they had one simulator in their cupboard. It was just that they were not taking it and using it. And you can see many centers have their Oculus, their Geo, or the HoloLens. In your medical college, in a tertiary center, they do have one, and the application has been made by us free of cost, and we are doing it for the love of MIGS. How much did the simulator train a safe environment for practice? Again, very likely was the more responses. And everybody would recommend the simulator among the 30 participants who underwent this. They would recommend the simulator, and the graphics and the structures were as real as possible. As you can see, a scoring of 4 and 5. It was a cross-sectional comparative study. Again, a questionnaire was sent out regarding the surgical planning, training, safety and recommendation, 3D realistic models and gamification features, and the satisfaction levels of this HoloLens versus a wet lab. A wet lab meaning it was more a dry lab with simuli eyes. And a pair t-test was evaluated, and it was statistically significant. Definitely p-value showed that it was highly significant between this versus the conventional training system for MIGS. So this is a medical virtual reality which is easily accessible in the palm of our hands. We are trying one to work in the smartphone as well, improving the quality of care, increasing cost effectiveness and accuracy, especially for transcending into the other novel MIGS procedures. According to our knowledge, there is no simulator till date. Many are focusing on cataract, but MIGS has fallen in the blind spot, but it is blooming and coming up. And IMG Holo is an app that is available free of cost on the Windows, which we have innovated. It's cost effective, accessible, and the users are showing a positive feedback, and we wanted to present this. And it is only a matter of time before holograms are not science fiction anymore. So this is a science-based reality, and we have brought it into the world of MIGS for training as well as refining the finite procedures for dexterity and more. Thank you once again for giving me this opportunity to present on this. Thank you.
Thank you, Dr. Prasanna. I think you're doing a wonderful work. The problem is, just one question I would like to know. I mean, your satisfaction levels very high, but they're based on like a survey, right? So is there any real improvement in when they actually do the surgical procedure?
So in any new procedure, it is always better that they have a orientation and then go back to
that's fine, but there is no actual, actual performance is still, I mean, that step is still to happen, right?
Yes,
okay,
yes.
The problem with this kind of studies is that there's a lot of wow factor with it.
Yeah.
So everyone who goes through this will say, wow, this is a fantastic thing, and the satisfaction rate would be actually reported higher. So it's very hard to say there's truly high satisfaction, or it's just because of the wow factor. So would you like to say anything on that?
So the satisfaction levels were predominantly focused on novice surgeons who are transcending into MIGS. Maybe another study regarding surgical versus simulative, how it has really...
Actual performance.
Yes, sir. Actual performance is something we are looking at also.
Thank you so much. Any question from the audience? Anyone? Yeah. Thank you very much.
Thank you, sir. Thank
Wonderful
you.
work. Thank you.
The next presenter is Dr. Priyalika Agarwal, and she is going to talk about to compare the optic disc cupping and RNLF thickness of glaucoma-like disc with normal subjects. Can we get her talk? Sorry, can we get her talk, please?
Good morning, everyone. My topic of presentation is to compare optic disc cupping and RNFL thickness of glaucoma-like discs with normal subjects. Coming to introduction, glaucoma-like disc refers to disorders which present with deep cup and pallor of neuroretinal rim, but they are not suffering from the disease process of glaucoma itself. The larger discs have larger cups, thinner rims, and larger cup disc ratios than smaller discs which may have no cup at all. A cup disc ratio of 0.8 may be normal in an individual with a large disc, whereas a cup disc ratio of 0.4 may be glaucomatous in an individual with a small disc. The aims and objectives of the study are to study and compare the optic disc area and cupping of patients of glaucoma-like disc with normal subjects by OCT, and to compare the RNFL thickness of the same by OCT. Materials and methods. It's a prospective study of 75 patients with informed consent conducted at upgraded Department of Ophthalmology at LLRM Medical College. Patients were selected from the routine OPD and categorized into 3 groups. Group 1 had 25 patients with glaucoma-like disc physiological deep cup with normal IOP. Group 2 had 25 patients in pathological cups with normal IOP, and Group 3 had 25 normal subjects which served as control. Inclusion criteria: patients with glaucoma-like discs, that is the optic disc resembling glaucoma with increased pallor and cupping, of age group of 15 to 55 years, IOP consistently below 21 mm Hg, and open angle and slit lamp gonioscopy. The exclusion criteria was diagnosed cases of glaucoma and ametropia greater than 5 diopters. We included all patients with normal IOP and they underwent IOP by Goldman's applanation tonometer. The cup disc ratio was assessed clinically using 78D lens, and all the patients were further evaluated by OCT. All the patients fulfilling inclusion criteria underwent visual field analysis by SAP. Coming to results, the total 75 patients in all 3 groups, out of which 39 males and 36 were females, included subjects in age group of 15 to 55 years, and there was equitable distribution in all age groups. The distribution of RNFL thickness in all the 3 groups, as we can see, the p-value between normal and pathological is highly significant, while the p-value for the normal and physiological cupping is not significant. The comparison of RNFL thickness in superior and inferior quadrant, the same was normal versus pathological, the p-value was significant, and for the normal versus physiological, the p-value was not significant, both for the superior and the inferior quadrant. The distribution of cup disc ratio as assessed by OCT, the cup disc ratio was significantly different in normal versus physiological as well as pathological. The distribution of neuroretinal rim, normal versus pathological was significant, and normal versus physiological, the neuroretinal rim was not significant. Coming to results, the groups were analyzed on the basis of mean of average RNFL thickness and mean of RNFL in all quadrants, and there was a significant decrease in average RNFL thickness, and also RNFL was decreased in all the quadrants, especially the inferior, in patients with pathological cupping. Subjects with physiological deep cup had RNFL thickness comparable to normal with no decrease, so deep physiological cups are normal cups. Optic nerve head parameters were analyzed in all the 3 groups using OCT, and it was found that for same optic disc area, there was significant increase in cupping, increase in pallor, and decrease in rim area in subjects of pathological cupping, which is statistically significant. It was found that subjects with physiological deep cup had all the optic nerve head parameters compared to normal, except the cup disc ratio, which was significantly increased. These are some images showing the bilateral high myopia and the pathological cupping of traumatic neuropathy. Coming to summary, imaging by OCT device can help to differentiate patients with deep physiological cup and glaucomatous disc and save the patients from the burden of anti-glaucoma medications, as physiological deep cups are healthy and they are similar to normal. The strategy of obtaining neuroimaging in all patients with suspicious optic nerve cupping is not cost effective. Therefore, OCT may serve as a fast and economical test to aid in determining whether a patient may have non-glaucomatous cupping requiring neuroimaging and further testing. Conclusion: We conclude from our study that glaucoma like disc can be both physiological and pathological, but the physiological discs are normal and they are not suffering from any form of optic neuropathy, whereas pathological discs arise from various causes of optic neuropathy, and to treat them, the underlying cause should be removed. These are the references. Thank you.
Thank you. Any questions from the audience?
Hewitts was used, ma'am.
And
Yes. Ma'am, optic disc area was measured from the OCT report itself.
okay. Clinically, did you look at the disc size?
What, sir?
Disc size,
Disc size I did not measure, sir.
because I think that's an important parameter. You know, if you have a physiological cup, you want to look at the disc size. I think you should have commented on that too. Any other questions?
I think one of the important criteria is the George Spieth classification of the disc, and that will help in the larger disc and a smaller disc, but you have to not measure the disc, so you don't know. Thank you.
Okay, thanks.
So the next presenter is Dr. Rekha. Yeah, okay, please. Dr. Arka Prava, yeah, Dr. Arka Prava. And study of the safety and efficacy of subtenon injection of mitomycin C augmented trabeculectomy.
So good morning everyone. Today I am going to present our work titled Safety and Efficacy of Subtenon Injection of 0.01% mitomycin C augmented trabeculectomy. Now in 2008, Lee et al. First described this technique of intratenon injection of using mitomycin C. So why should we consider this subtenon injection of mitomycin C? It ensures precise delivery of desired amount of mitomycin C, and it ensures diffuse and elevated blebs, and it promotes less scarring and vascularization, and there is no risk of retained sponges that in some case reports have reported, and it also reduces the surgical time. So this study is aimed to assess the efficacy and safety of this low dose subtenon injection of mitomycin C in trabeculectomy. Now it was a prospective interventional study conducted in Sri B.M. Patil Medical College, BLD University, Bijapura, for a duration of 1 year in 30 eyes. And we included patients with age more than 25 years who are having primary open angle glaucoma, primary angle closure glaucoma, pseudoexfoliation glaucoma, and normal tension glaucoma with cataract which required surgical intervention. And we excluded those patients with prior ocular surgeries or immunodeficient condition, connective tissue disorders. We recorded preoperatively. We recorded baseline IOP, baseline vision in logMAR units, and we did a gonioscopy and automated perimetry for all the patients. Now the mitomycin C that we used for the injection, it was 0.1 milligram per milliliter mitomycin C, which we used 2 milligram powder of mitomycin. We diluted it with 5 ml of sterile water. We in 1 ml tuberculin syringe, we withdrawn 0.1 ml of the MMC, and we diluted it with 0.3 ml lignocaine. So from this 0.4 ml solution, we used 0.1 ml for the subtenon injection. Now it all were single site combined SICS trabeculectomy performed by a single surgeon, and the site of injection was 8 millimeters distal to the limbus. Now this is a video showing the subtenon injection. Now this is the 8 millimeters away from the limbus, and after injection of the mitomycin C, we gave a thorough massage from away from the limbus. After that, we have performed a routine trabeculectomy surgery using a fornix blessed conjunctival flap. And we did follow-ups at day 1, first week, 1 month, 3 months, and 6 months. And for outcome measure, we measured the IOP, visual acuity in logMAR, and we graded the bleb morphology using Indiana bleb grading system. And we also noted for any complications. Now we quantified the complete success as if IOP is between 6 to 18 millimeters with no anti-glaucoma medications, and qualified success if it required anti-glaucoma medication, and failure if IOP was more than 18 with anti-glaucoma medications. Now coming to results, mean age of the patients were 66.93 years, with 19 being male, 11 being female, and 19 patients were also having a primary open angle glaucoma and 11 primary angle closure glaucoma, with mean IOP being 31.40 and mean baseline vision being 1.11. Now this chart shows the IOP reduction, and we can see that there is a significant reduction in IOP at 6 months to 9.55. So there is 69.57% reduction with p-value of 0.01. Now this shows the bleb characteristics over the follow-ups. Now we can see we have achieved a favorable bleb architecture at the end of 6 months with a low vascular bleb and well-formed diffuse bleb. And this photo shows the bleb architecture over the follow-ups. At 6 months, we can see a thin posterior diffuse bleb has formed. Now in 28 cases we have achieved complete success, and in 2 cases we achieved qualified success. And in 20 cases we have noted an corneal edema, and 1 hypotony was noted, but it was managed conservatively. Now coming to discussion, in study by Gupta et al, they have used 0.02% mitomycin C, in which they have achieved a mean IOP of 13.50 and total reduction of 68%, which was comparable to our study. Now, as per Maheshwari D et al study, who used 0.1 milligram mitomycin C, their success rates were much more convincing, was much less convincing than ours. Our success rate was 93.33%, and they have achieved an overall success rate of 90.5%. So, to conclude with, subterranean injection of mitomycin C demonstrates efficacy in reducing IOP and promoting favorable bleb architecture. Using a lower mitomycin C dose allows for minimal complication without sacrificing the efficacy, and surgeons can confidently consider the mitomycin C application, this mitomycin C application route, for offering a practical alternative to the cumbersome soaked sponges approach. So, thank you very much.
Thank you. How much volume did you inject?
Yes, sir.
How much volume did you inject?
Sir, 0.1 ml.
0.1 ml. Okay. And you didn't have any control group, it was just
No, control, just
a cold study. Okay, thank you. Any questions from the audience?
No, we didn't go behind the globe, ma'am. After injecting that injection, we did we just massaged that thing.
We go to the next.
Yeah. So the next, thank you very much. The next presenter is Dr. Muhibin Abul Qadir, and Dr. Muhibin will be presenting to screen myocilin mutation in a large South Indian family with early onset, juvenile onset, and primary open-angle glaucoma.
Yeah, they'll be talking about screen myocilin mutation in a large South Indian population of early JOAG and POAG. These are my co-investigators. So the background, a 26-year-old female high school teacher present a OPD, a busy OPD with defectivation of 1 year duration. Pressures of 50 and 666 and 612 vision and point and cup, ill-sustained people. This is just a cupping. The point is a very advanced, pale-looking cupping. So we pulled her brother, who was came along with her sister, and we found that her pressure was of 54 and 46. Often people defect and pressure is 50, 40 and point and cup. This is the advanced cupping, symmetrical and very pale disc. So we had a history. We took a history of families with glaucoma, the mother and grandmother. Then we thought it is something. We explored the place called Kadaladi, which is 100 kilometers from Madurai, Ramnath district, to look at what happened to the particular village. So this is the one we have comprehensive examination done campsite. We took a sit-lam, we done IID, we done gonia, we done a preliminary examination. We also took a blood sample for genetic counseling. We took a handheld fundus photograph, then our counselor to counsel all that, and we done this spot, the part of World Glaucoma Week a few years back. Then our main objective is to screen myocilin mutation in large South Indian family with early onset juvenile open glaucoma and adult onset POG glaucoma. We done a comprehensive examination, I told you, in appellation, and also in gonioscopy and a base camp, an IND, and also fundus picture and also blood sampling. So we took an individual of the POG and angle closer glaucoma. We excluded from the study. And our main of the age group is less than 40 years, expressed in a POG, younger age group. The age of presence is 31, and gender is the equal distribution on all the groups. I look at the IOP is around 29.2 millimeter mercury, expressed in a POG compared to suspect and control is around only 13 millimeter mercury. And coverage ratio is 0.87, highly significant compared to POG suspect and a control. And CCT also is lesser compared to POG suspect and control. So this is a bar diagram which says the more IOP, the lesser CCT, and more coverage ratio, especially in a POG group. So we also compared a proborn, siblings, and offspring. We found the proborn and siblings are severely affected, whereas the offsprings are unaffected, but they are myocilin positive. So this is a picture, fundus picture of the both A and B and C are both of the proborns and proborns, brother and sisters, and offspring also having myocilin positive but yet to develop glaucoma. So the rate of progression among the proborn and sibling especially in fields is 2.8 decibel per year. And the age group I told you is around 20 to 30 years. Mostly people are affected in diagnosed glaucoma at the age of 20 to 30 years. So genetic blood sampling was extracted from all the patients for written consent form, and DNA extraction was extracted with, and also bidirectional sequencing performed for screening myosin mutation, and whole sequencing was performed for myosin negative POG patients. And then the researcher came to the campsite for Kadaladi, where there's the Dharmalingam and Dr. Baranjaran and my fellow Geethu all came to the camp center to do a genetic analysis. This the pedigree was put. See the pedigree, the arrow mark is then the Probon. And Probon, two brothers are myosin positive glaucoma. Probon sister is glaucoma. Probon mother is glaucoma. Probon grandmother is glaucoma. So Probon's again mother's brother is glaucoma. So whole family is affected with glaucoma with a high intraocular pressure. So out of 40 members, we screened for myosin meters in axon number 3, and we found out N480K in axon 3 was found in 20 members. And among 20 members, 15 were POG, and 3 were GOG suspect, and 2 were control. Youngest to get was 10 years old. The 18 mutations people were more than 10 years of age. The 17 had a high penetration of 94%. So POG suspect, GOG suspect 2 carry a mutation, and other carry a mutation in axon 1 of the myosin common variant. 2 control we need to closely watch out for developing glaucoma. So N480K in our study is an alteration, is characterized by high intraocular pressure, and younger age, the disease presentation, and nearly 80% of the people, like out of 80% of the patients need a glaucoma filtering surgery, like trabeculotomy to control glaucoma. So whole exome sequencing done for people of POG suspect, and we identified polymorphism L432V in CYP1B1 gene, and also R76K in a myosin gene. The further screening of this polymorphism and close relatives revealed the inheritance in the family. So this is associated with the POG suspect. So in conclude, GOG had a mostly females, and the high intraocular pressure of 36.7 mm mercury, and a POG was where the males to female ratio 1:1, and the IOP is around 20.57. To conclude, a strong familistic glaucoma with high intraocular pressure and younger age of presentation like our study, warranted genetic testing of myosin gene mutation. Younger carriers identified in the study need to be followed carefully for the symptom of initial intervention. The emphasis the importance of screening of myosin gene and other gene variant in a family-based studies. An important GOG patient with a myosin mutation are reported to have high intraocular pressure in early onset. If left untreated, result in severe visual impairment. The screening myosin mutation among GOG patients of this family help detect the disease early. Early detection will allow better therapeutic intervention. Thank you.
Thank you. I think it's a wonderful work. They were all high pressures glaucoma, GOAG or POAG.
They were high pressure.
Okay. And large majority of them, they had the mutation positive.
Most positive.
And were there any cases where the mutation was positive but they didn't have like
we have 3 patients, they had to develop a disease. They are 4 years and 3 years, and one more is around 10 years. So we are just watching them every year. We try to see something we can do for them.
Any questions from the audience?
What is the cost of testing? Is there any limiting factor for doing this testing?
I think because we have large pool of patients, so we pulled it for some time, then we done one go. I think we can able to do it. Our research centers have some funds, so they can able to do it.
Because globally now, this is the way forward. More and more evidence shows that genes are the way forward for glaucoma. Thank you. Okay, so we got the next presenter, Dr. Rubaiyat Sharmeen, and she is going to present on the study to find out the role of low serum vitamin D3 as a risk factor in primary open-angle glaucoma.
Good morning, everyone. Today, the topic of my presentation is a study to find out the role of low serum vitamin D3 as a risk factor in primary open-angle glaucoma. I have no financial interest in the study. First, coming to the introduction, as we all know, glaucoma is a chronic progressive optic neuropathy, and it's the most common cause of irreversible blindness in the whole world. So, early diagnosis and appropriate treatment is very important. However, intraocular pressure is one such important risk factor of glaucoma that can be modified. So, the research objective of our paper is to evaluate the association between serum vitamin D3 and glaucoma. Now, what is the role of vitamin D3 in primary open-angle glaucoma? For that, we have to understand the pathogenesis of POAG, which is apoptosis in the trabecular meshwork, accumulation of extracellular matrix protein, and cytoskeletal disruption. This leads to increased oxygen-free radical in the aqueous humor, and this causes increased TGF-beta SMD3 pathway in the trabecular meshwork cells. And all this leads to increased extracellular matrix protein, fibrosis, and increased resistance in the aqueous flow, and this causes high IOP. Now here comes vitamin D3 to the rescue. Vitamin D3 acts on this step and blocks the whole process. So IOP is maintained. Now coming to the material and methods, this is an observational case control study. We have selected 50 patients of POAG as cases and 50 normal age and sex match individuals as control. The inclusion criteria is diagnosed cases of primary open angle glaucoma between the age 40 to 50 years, and we excluded patients more than 50 years of age, postmenopausal women, and the patients with metabolic and retinal disease which alter the vitamin D3 level. The study period is for 6 months, and the study took place in AIOC Kolkata. Informed consents were taken, approved by the ethics committee. A detailed history taking and slit lamp examination is done for the cases and the control. We have measured IOP by Goldman applanation tonometer. We have done detailed fundus examination by 90D lens, the perimetry to check the visual field, and obviously gonioscopy to rule out angle closure. The serum vitamin D3 was measured by ELISA kit. Now coming to the results, collected data were analyzed using the principle of the descriptive statistics, and student t-tests were applied when required. This is the spread of the data according to age, sex, and religion wise, and we have found all the data has p-value 0.05, which is significant. This is the chart of the severity of the glaucoma, both cases and control, in the both eyes, OD and OS, and which is also found out to be significant. And this is here we can see in this diagram that mean vitamin D3 level in the cases is much less than the controls, and this is also significant. Now coming to the discussion, there are a lot of studies happening around the world in this topic, and we have selected some, and all of this shows the inverse relationship between the glaucoma and the serum vitamin D3, and our study we have also found the same. Now to summarize, patients who have visual field loss, they try to restrict their daily outdoor activities, and so they get less sun exposures, and all this leads to vitamin D3 deficiency in these patients. As we all know, vitamin D3 is an excellent anti-inflammatory agent, and it also has neuroprotective effects. So in those patients, they are very much prone to optic nerve damage, and the further visual field loss in happening, and the vicious cycle continues. Now to conclude, lower serum vitamin D3 is significantly associated with risk of glaucoma. The take-home message from our study is additional vitamin D3 supplementation could prevent the progression of the optic neuropathy. There are obviously some limitations of our studies, which is small sample size, cataract were not taken into consideration, and vitamin D3 in aqueous humor is not measured. These are some of my references. Thank you.
Any questions from audience side?
Thank you. I have a question for you. So in your study, you said additional vitamin D supplement will help progression of optic neuropathy. Do you say that for established glaucoma, or do you say that everyone should have a normal vitamin D3 to prevent glaucoma developing?
We have, this is actually an observational study, not intervention. So we have an ongoing interventional study that is happening, and we are giving 40,000 international unit per week vitamin D3 doses to see the established glaucoma, so they can prevent the further IOP increasing. Not for prevention, for the established glaucoma.
Established glaucoma.
Based on the severity of the glaucoma also, the vitamin D3 levels changed?
Yes, yes. The more severe the glaucoma, we have found there are less vitamin D3.
Did you measure this sun exposure, the hours of sun exposure in these patients?
No, they are mostly in the eastern zone population, so
The
no.
sun exposure is supposed to be good.
Supposed to be good.
You're right. So I live in UK, and there is no sun there. So I'm just thinking why that may be one of the why the glaucoma is more common in this part.
Yeah.
a lot of sun exposure. But anyway, thank you. Thank you very much. Okay, so the next presentation is by Dr. Suvarna Yeluguri. Hello, Dr. Suvarna, and she is going to present on comparison of choroidal thickness and lens thickness among subtype of angle closure disease.
Good morning, everyone. Today's my topic is comparison of choroid thickness and lens thickness among subtypes of angle closure disease. Glaucoma is characterized by a group of disease rather than a single disease process that differ in their clinical presentation, pathophysiology, and treatment, which causes irreversible blindness in the world, which was broadly divided into open angle and closed angle. Even though open angle glaucoma is more common, the proportion who became blind due to closed angle is over 25% more because of its acute presentation, which is resulting in about 4 million population going to irreversible blindness in the world, thus ranking a second leading cause of blindness worldwide. Coming to primary angle closure disease, until recently it was considered as an anatomical disease because of shorter axial length, flatter cornea, shallow anterior chamber, and thick lens, etc. But it could explain only 1/3 of the variance in the prevalence of primary angle closure disease. So some other factors are also responsible for the development of primary angle closure disease. During the past few years, because of development of advances in the diagnostic modalities, there is a rise in the role of choroid in the pathophysiology of primary angle closure disease. In a study by Singh et al., they had found a correlation between choroid thickness and intraocular pressure in primary angle closure glaucoma in the Indian population. However, they have not evaluated the choroid thickness in different subtypes of the angle closure disease, including primary angle closure suspect and primary angle closure eyes. And also, lens thickness was not assessed, which could be a confounding factor, as increased lens vault is a risk factor for angle closure. The purpose of this present study was to evaluate the choroid thickness and lens thickness among various subtypes of angle closure disease and compare them with healthy controls. It is a cross-sectional study, cross-sectional observational and comparative study. Institutional committee ethical committee approval was obtained, and study was conducted at our eye hospital between June 2022 and Feb 2023. And inclusion criteria is based on International Society of Geographical and Epidemiological Ophthalmology, primary angle closure suspect, primary angle closure glaucoma, and a healthy controls comprising of eyes with baseline intraocular pressure less than or equal to 21 mmHg, open angles on gonioscopy, and normal optic disc. Exclusion criteria was patients less than 30 years of age, secondary glaucoma, anterior segment pathologies like conjunctivitis, keratitis, or uveitis, and history of opaque ocular media, ocular surface disorders, ocular surgeries, and ocular trauma, and other ocular diseases such as retinopathies and choroidopathies, or systemic diseases that may affect the vision. The subjects who fulfill the inclusion criteria after complete ophthalmic examination, lens thickness was measured using an automated optical biometer. 3 measurements were taken, and an average of them was considered for analysis to minimize the bias. Choroidal imaging was done using enhanced depth imaging OCT. The scan used for viewing the choroid was HD cross 6 mm line EDI mode, and the images are documented. And this is the image showing the choroid thickness was measured from the outer portion of the hyperreflective line corresponding to the retinal pigment epithelium to the inner surface of the sclera, known as the choroidal scleral interface. The 2 points are chosen in such a way that the line drawn between them is perpendicular to the RPE line. Measurements are typically taken beneath the geometric center of the fovea. Both the vertical and horizontal subfoveal measurements were taken, and an average of the 2 is considered as a final value. Image obtained with signal strength greater than 6 was considered. And the sample size was calculated using this formula, and we got 21 in each group. It was further increased from 21 to 31 in each group to document the contingencies such as non-response or recording error. And these are the following tests performed for statistical analysis in this study. And coming to results, 124 eyes were included in the study and 31 in each group. And these are the demographic characteristics of the study, which showed an increasing trend in the age, and a female to male ratio is equal in all the groups with a slight higher predominance of females. And the intraocular pressure and central corneal thickness was measured, and the intraocular pressure was found to be statistically significant on comparing the groups, and central corneal thickness was not significant statistically, but it was used as a correcting factor. And the mean choroid thickness among the study population was found to be increasing from primary angle closure suspect to primary angle closure glaucoma, and also comparison to controls. This is the
plot showing the pairwise comparison of the mean choroidal thickness between the groups, which was found to be significant when compared to the controls, and on comparison between the groups. And this is and then the mean lens thickness values among the study groups was found to be significant when compared to the controls. But it was on pairwise comparison, there was no much difference between the groups, but it was found to be significant when it is compared to the control group. And coming to discussion, in the present study, choroidal thickness and lens thickness among primary angle closure suspect, primary angle closure and primary angle closure glaucoma and healthy controls were analyzed and compared. Most of the studies have demonstrated that choroidal structure and function may contribute to the pathogenesis of angle closure disease. And in this study, we used AIOCT to evaluate the macular choroidal thickness in different subtypes of angle closure disease. The subfoveal choroidal thickness in all subtypes of angle closure was significantly thicker than in healthy control eyes. We found that angle closure eyes had a greater baseline choroid thickness than healthy eyes. In addition to the shallow anterior chamber, shorter axial length, as said earlier, the choroidal thickness might be another anatomical characteristics of primary angle closure eyes. Greater baseline choroidal thickness may cause a greater tendency to choroidal expansion, which may be a risk factor. Choroidal enlargement is a dynamic feature seen in both untreated and treated acute and chronic angle closure disease eyes. An increase in the choroidal volume would lead to an increase in the posterior segment volume and pressure, which would cause the lens to move anteriorly and the anterior chamber to become shallower. An increase in episcleral and orbital venous pressure may cause choroidal enlargement. When the osmotic pressure of the extravascular choroidal stroma goes up, it leads to the leakage of big proteins that promote fluid flow into the extravascular space. The authors, in some studies, assume that initial angle closure represent choroidal growth in already tiny, physically predisposed eyes. Various studies have demonstrated that primary angle closure glaucoma have a substantially bigger and more anteriorly positioned lens compared to the normal eyes. In a study by Chakrabarti et al., different lens parameters were analyzed, and the mean lens thickness was more in all subtypes of angle closure disease compared to the control group and was statistically significant. These findings were similar to that of our study. It was also observed that there was a direct correlation between the increasing age and lens thickness, which again correlated directly with the shallowing of the anterior chamber. The onset of age-related lens changes could also contribute to the increased lens thickness and forward movement of the lens. My strengths are choroid thickness among different subtypes of primary angle closure disease was measured. Limitations were choroid thickness measurements were done manually, which could be subject to bias by the examiner. We measured only the subfoveal choroidal thickness, and dynamic measurements or changes in the choroid in other segments were not considered. Conclusion, primary angle closure disease eyes have increased choroid thickness and lens thickness than the normal eyes. Increasing choroidal thickness might be another anatomical characteristics of angle closure eyes. This observation may support the hypothesis that choroidal expansion is a contributing factor to the development of primary angle closure disease. My recommendations are automated segmental measurement software is want for a more objective evaluation of choroid thickness, and further studies with larger sample size and representing different groups of the population based on age, gender, race, and ethnicity can generate a normative database for choroid thickness measurement by EDI-OCT. Thank you.
Very good presentation. Any questions from audience side? I have one doubt. Do you have any correlation between iris thickness and choroidal thickness in your study?
But iris thickness was not measured, ma'am.
That plays a major role in angle closure.
Yes, ma'am. But correlation was not done, ma'am. We have to.
Vitreous length or volume? Did you measure? Lens to vitreous length?
Lens to?
Vitreous ratio.
Ratio. That was not done.
Okay, so the next talk is Dr. Anuradha, and she's going to talk about iridocorneal endothelial syndrome, our experience from a series of patients in a tertiary care setting.
A very good afternoon. Iridocorneal endothelial or eye syndrome is a spectrum of 3 overlapping conditions, which is a primary anomaly of the corneal endothelium, iris and angle, causing universally secondary angle closure glaucoma, and is seen to present commonly in middle-aged women. Today we present a series of 5 cases which include 4 women and 1 male patient. Our first patient was a 43-year-old female who presented with diminished vision in the right eye. Her vision in the right eye was 6/9, which was not improving further, and IOP with Goldman applanation tonometry was 36 millimeters of mercury. On examination, this patient had ectropion UVA with pedunculated iris nodules, and fundoscopy showed a cup disc ratio of 0.8:1. Visual field showed advanced field defects, which was corroborated with OCT RNFL. Anterior segment OCT showed synechial angle closure in all quadrants, and specular analysis showed reversal of cell borders with a central bright spot, which is pathognomonic of eye cells. So based on clinical features, this patient was diagnosed as a case of Cogan-Rees syndrome and was managed medically, failing which she was taken up for augmented trabeculectomy in the right eye. Certain special considerations were done in this patient: a longer exposure time, a slightly higher concentration of mitomycin C, and a larger sclerostomy was done after careful planning and proper counseling of the patient to achieve better surgical outcome. In the early postoperative period, this patient had a higher IOP and a flat bleb, which was managed with the removal of reversible sutures and ocular massage, with which her IOP was brought under control, and the bleb was adequate. The second patient was a 47-year-old male who presented with vision loss in both eyes. However, his vision was found compromised only in the right eye, which was 6/9 with no further improvement, and IOP was 36 millimeters of mercury in the right eye only. The anterior segment showed ectropion UVA, pedunculated iris nodules, and atrophic and stretch iris holes in right eye only. Fundus examination was normal in both eyes. Visual field showed few paracentral scotomata in both eyes, which were not fulfilling Anderson criteria. This patient was diagnosed as a case of Cogan-Rees syndrome of right eye and was managed with topical anti-glaucoma drugs. Presently, he is on maximal medical therapy. He has been counseled that he may require surgery in the future and is managed on with medical therapy. The third patient is a 33-year-old female who was a known case of eye syndrome and was referred for management of secondary glaucoma. Her vision in the left eye was perception of light with inaccurate projection of rays, and IOP was 50 millimeters of mercury with total glaucomatous atrophy. Anterior segment showed characteristics of Cogan-Rees syndrome. In this patient, the primary aim was to salvage the eye and reduce the IOP, so the patient was taken up for transscleral diode laser cyclophotocoagulation after counseling of the patient regarding guarded visual prognosis. A 40-year-old female presented to us with diminished vision of the left eye. On examination, her vision was 6/18 with IOP of 28 millimeters of mercury. She had iridocorneal adhesions with microcystic edema and a beaten metal appearance, and no iris nodules. Visual field showed biarcular scotoma, which was corroborated on OCT. And anterior segment OCT showed synechial angle closure with pleomorphism and polymechism and reduced cell density on specular analysis. This patient was diagnosed as a case of Chandler syndrome due to predominant corneal features. She was managed with YAG laser PI in both eyes, followed by topical anti-glaucoma drugs, and is presently maintaining her IOP in target range with medical therapy. Our last patient was a 37-year-old female who presented with glare and halos in the left eye. Her vision was and IOP were within normal limits in both eyes, but the left eye showed correctopia polychoria, and her fundus, visual fields, and OCT RNFL were also normal in both eyes. However, specular analysis showed pleomorphism, polymechism, and a reduced cell count compared to the right eye. This patient was diagnosed as a case of essential iris atrophy without glaucoma and is presently on close follow-up with counseling without any management. So eye syndrome is now considered as a constellation of three entities: Cogan-Rees, Chandler, and essential iris atrophy, with major overlap between the three conditions. The etiology is still uncertain. Viral etiology has been hypothesized. It is said to be affecting middle-aged females. However, literature regarding this has been changing. The essential pathogenesis is a metaplastic transformation of corneal endothelium causing an abnormal membrane which progresses onto the angle and iris, causing secondary glaucoma and iris changes. So in this case series, we encountered a male patient. Also in the 5 patients, we encountered different types and different stages of eye syndrome, and we were able to customize the treatment according to patient requirement. In 2019, Malhotra et al. Had published literature in which there was a male preponderance of up to 62% which was published, and they were also able to demonstrate 2 different morphology of eye cells by in vivo confocal microscopy, which could affect the prognosis and presentation of disease. Eye syndrome has also been seen to present bilaterally, which could be asymmetrically in the 2 eyes or as 2 different syndromes in each eye of the same patient. It has also been seen to present in the pediatric age group, which has to be managed surgically, or it could even be associated with certain syndromes such as Down syndrome. Predominantly, Chandler syndrome has multiple predominant corneal findings, while Cogan-Rees and iris atrophy have iris findings. The specular analysis shows reduced cell count with pleomorphism and polymagatism. The pathognomonic eye cells may not be seen in all cases. Visual fields OCT are used to see glaucoma progression. Management is tedious as this is a relentlessly progressive disease. Medical management is maintained to the longest extent possible. Corneal edema can be reduced using hypertonic saline and lubricants as well as IOP reduction, for which aqueous suppressants are used. And Rho kinase inhibitors are known to reduce IOP as well as improve endothelial functioning and morphology. Antiviral therapy is not recommended at present. Laser peripheral iridotomy is associated with high closure rates but can be used as a temporizing measure. Surgery, augmented trabeculectomy with certain modifications which have not yet been proved by literature can be used as a primary surgical modality, and glaucoma drainage implants are reserved for cases of failed trap because they are associated with slightly lesser chances of failure. Other surgical modalities under evaluation are Zengel stent and insulcus or pars plana implantation of glaucoma drainage implants. And patients with advanced corneal decompensation may require endothelial keratoplasty or penetrating keratoplasty with or without lens extraction. Transplantation of cultured human corneal endothelial cells are also under research. To conclude, eye syndrome is a progressive disease which universally leads to secondary angle closure glaucoma. At present, it has been reported to affect all genders, any age group, and that the onset and progression may depend on morphology of the eye cells, as has been seen by in vivo confocal microscopy. Management is tedious. Patient counseling is very important to make them aware about the requirement of surgery and multiple treatment modalities and guarded visual prognosis. These are my references. Thank you.
Nice presentation. What will be the general surgical outcome of trabeculectomy in these patients?
Ma'am, generally trabeculectomy after a period of time, it depends from patient to patient the rate of inflammation, but it tends to fail with time because the pathology is progressive. So the sclerostomy tends to close, the iridotomy tends to close, and it can fail with time.
So one of the cases where we can go for primary tube.
Yes.
Ma'am.
So what is the role of PI in these patients?
Ma'am, PI again is sought with very high failure rates because the iridotomy
so
closes.
What is its role, whether you do or not? What is its role? It is
Ma'am,
not preventing PAs.
in two of our patients, in one patient, she had come with a prior PI. In the other, we had done it, but it was just as a temporizing measure while the medicines took their effect to reduce the IOP.
See, PI we will do only for pupillary block, mainly for pupillary block. How here it helps? I'm asking.
Ma'am, since the pathology is secondary angle closure, so
it is
sorry, I will agree. I completely agree with you. That's the two concern I have. Never do a PI in these cases, not even a temporizing measure, because this is a uveitic type of a secondary glaucoma. So PI, in fact, is contraindicated in these cases. And I will be very keen to know how is your first patient doing with the trap. This case has got high success or high failure of trap, and completely agree primary tube is the treatment of choice. I'm very surprised that 3 of your patients still manage on drops because they are very aggressive glaucoma, and do a primary tube, never do a PI, and don't plan a trap.
Thank you.
Our next presenter is Dr. Benjamin Nongram, and Dr. Benjamin is going to present on glaucoma burden and its profile in a tertiary care center of Northeast India. Over to Dr. Benjamin.
Respected members on the dais and my dear colleagues, my presentation is on glaucoma burden and its profile in the tertiary care center of Northeast India. Glaucoma is a form of progressive optic neuropathy where of the known risk factors, raised intraocular pressure is the most common. Now, it is the 4th leading cause of moderate to severe visual impairment and the 3rd leading cause of blindness. The objective of the study is to describe the profile and distribution of glaucoma. Coming to methodology, this is a retrospective observational study, retrospectively from 2016 to 2014 and prospectively from 2017 onwards till 2022. Sampling type all consecutive patients that were diagnosed with glaucoma. Now, glaucoma were diagnosed based on the operational definitions laid down by ISGEO and CGRN. Now, the methodology involves that all patients that attend OPD are routinely screened for the vision, refraction, IOP, and fundus examination. Now, all patients that have any suspicion findings, then they would undergo a detailed examination as for any patient in order to diagnose glaucoma. Now, glaucomas are diagnosed based on the level of evidence. The level of evidence one, when there is visual field finding, which is appropriate or which is correlated with that of the cup disc finding, and which suggests of glaucoma. Now, the level of evidence too, when the field are not reliable, but when we are able to see that there's a cup disc, especially the vertical cup disc ratio of more than 99.5th percentile, which is more than 0.9. And the level of evidence 3 is that when there is, when the visual field is not possible or the cup disc assessment is difficult. So based on the level of IOP, which is more than 26 millimeter based on the 99.5th percentile. The study was approved by the Institute Ethics Committee. Now here are the results. Over the last 9 years, we diagnosed 449 patients of the 89,000 plus patients that we have seen, new patients. Now we have divided into two groups. Now less than 40 years constitute to about 20%, while 40 years and more is about 80%. The distribution in 40 years and more is that POAG is the commonest one, and followed by PACG, and this is quite significant in female. The association p-value is less than 0.001. In less than 40 years, JOAG is more common, followed by secondary open-angle glaucoma, which are mostly because of trauma, angulation, or uveitic inflammatory in origin. Family history just contributes to about close to 5%, which could be either of the parents. Now hypertension leads, followed by diabetes. What is interesting is COPD. We found that quite a significant number of COPD have the risk factors as the risk factors, and also hypothyroidism and CAD. The discussion is that the prevalence is somewhat lesser, though it is a hospital-based study compared to other hospital-based study in India. Population-based showed about 2.5%, other hospital-based showed about 5%, but ours is only 0.5. Probably because we have included all the age groups, and probably because it is in the high altitude with the lower atmospheric pressure contributing to lower IOP. COPD, the shared risk factors, there is risk factors of more than one. Probably the observed effect could be attributed to shared risk factors like advanced age, smoking, vascular dysfunction, and steroid usage. And CAD also have the high risk of developing glaucoma and vice versa. As for hypothyroidism, the proposed mechanism could be because of the deposition of hyaluronic acid and mucopolysaccharides within the trabecular meshwork. Conclusion is PACG is high in our part of the country, which is similar to that of population in China and Japan. And systemic conditions like COPD and hypothyroidism should also be kept in mind whenever a patient comes to OPD. Thank you.
Thank you. You got quite a high percentage of patient under 40 with glaucoma compared with the known parameters. And do you think, have you taken the history of steroid use in all this patient? Because one of the factor could be non-COPD related steroid use over the counter for skin condition and all that.
Yes, sir. So most people in the Northeast, they smoke from early age. That could be one of the contributing factors. Not really COPD. COPD we see mostly in age more than 40 years. But I think it is the smoking that does that contributes.
Smoking is there.
Smoking, most of them start from the age of 18 years, 15 years in rural population.
Thank you. Okay, thank you very much. Thank you.
Thank you, sir.
Okay, we move on to our last talk, Dr. Saksham Mathur. And Dr. Saksham will going to talk about comparison of lens and iris parameters in angle closure glaucoma versus open angle glaucoma in ASOT. Is Dr. Saksham here? Oh.
A very good afternoon to you all. I'm Dr. Saksham Mathur, a final year postgraduate from Maulana Azad Medical College. And today I'll be speaking on the very important and upcoming topic of comparison of lens and iris parameters in angle closure versus open angle glaucoma on ASOCT. First of all, why do we need to study about this topic? Because primary angle closure glaucoma accounts for about 50% of global glaucoma blindness, and it disproportionately affects people residing in Asia, that is us people. There are various pathophysiologies which have been discussed for the causing angle closure, including pupillary block mechanism, the iridotrabecular contact, and various lens and iris parameters which will be discussed in our study. Coming to the age-old discussion of gonioscopy versus ASOCT. Gonioscopy we know is the gold standard for diagnosing angle closure. However, it is a subjective test requiring a longer learning curve and most of all requiring contact. So in post-COVID situations, we have a newer modality coming up, that is ASOCT, which provides a rapid 360-degree view of the angle. It is an objective test and it is non-contact. Our study group included patients with primary angle closure glaucoma at any stage, that is PACS, PAC or PACG. And control group included age and gender matched open angle glaucoma patients which were undergoing cataract surgery. The parameters evaluated in our study were following. We did ASOCT by KCR2 machine, which is a type of swept source OCT. The parameters evaluated were lens parameters including lens vault, lens thickness, anterior vault and the relative lens vault, iris parameters like iris curve, iris area, iris thickness, angle parameters like angle recess area, angle opening distance, the trabecular iris space area, anterior chamber depth and the iridotrabecular contact index. Coming to the results. Our study included 81 eyes with angle closure glaucoma and 32 eyes with open angle glaucoma, and here are the results. Lens vault. What is lens vault? It is basically the distance between the anterior pole of the crystalline lens from the line joining the two scleral spur. It is a newer modality which is coming up and is a basic risk factor for causing angle closure. So lens vault was found to be significantly higher, that is 0.59 in ACG as compared to only 0.2 in OAG. The relative lens vault was also found to be higher in ACG, that is 0.24, and lower in OAG, that is 0.07. ACG patients were found to have a very bulky lens, as evident by the lens thickness, which is more in ACG as compared to OAG, and leading to a shallow anterior chamber depth in angle closure glaucoma. This is a slit lamp picture of a patient with a very high lens vault, that is 1.33. And corresponding to that, there is the ASOCT picture where we have highlighted the lens vault of 1.33. These are the iris related parameters. So ACG patients were found to have a lesser iris curve, a lesser iris area and greater iris thickness. What is the importance of studying these parameters? First of all, I want to point out that all our ACG patients had already undergone a laser PI, and a laser PI is known to alter the iris parameters. That is why a few previous studies which have been published have shown that ACG patients have a larger iris curve. But in our study, they were found to have a lesser iris curve because they had already undergone a laser PI. Iris thickness was found to be at 750 microns, slightly greater in ACG patients, implying a thicker iris in ACG, which also contributes to angle closure. This is a ASOCT picture showing all the parameters studied in our study. We also did a correlation study between the post-op IOP reduction and the pre-op ASOCT parameters. And it was found that post-op IOP reduction was positively correlated with pre-op iris curve and negatively correlated with the iris thickness. The limitations of our study included that there was a significant difference in sample size, that is 81 eyes of ACG and 32 of OAG, so which can produce a bias. Then all of our ASOCT of angle closure was done post-PI. So in our future study, we plan on doing ASOCT in angle closure pre-PI for better parameters. And in ASOCT, as we all know, we need to manually identify the scleral spur, which leads to various biases in identifying and the scans. Now, how do we utilize this study in our future clinical studies? We need to generate a normative lens fault databases because it can be used as a screening tool predicting the angle closure risk of the patients. Planning surgery in ACG patients. The patients which have a higher lens fault were found to have greater intraoperative difficulties. So we can plan an early lens extraction in them. And ITC index is an upcoming parameter which is an objective method in addition to gonioscopy for quantifying angle closure and for counseling the patients, as we can show them the scans and tell them these are your angle closure potential. Thank you.
In your study to justify that conclusion.
Yes, previous studies have shown that PSC patients have a greater lens fault as compared to PSCG, but we didn't do that analysis in our study.
Yeah, because that was the important issue, because your conclusion was,
Yes.
you know, that you could do it, but your data doesn't support that. Okay, thank you very much. Any questions?
Why did you choose POAG as your control group? Why not normal? What is the
Ma'am, we are undergoing another study. We are comparing ACG versus controls. So that is another part of the study. And then we plan to combine all the two studies and compare PACG with OAG with control group for better idea of how to plan them surgically.
So but you have not presented the normal.
That study is still undergoing, comparing with healthy controls. This study included only ACG versus OAG.
Thank you.
So there was the last. Any presenter left?
No, all done.
All done. I think there was one missing.
One
so
missing, yeah.
So he has
Is
not
Dr. Suman Sharma here? No.
Okay, so we basically close this session. Thank you all very much for being here, and we'll compile the results and give it back to the
Thank you all
Thank you.
presenters.
Thank you very much.